group is common that any patient presented to the ERs or presenting to the hospital, you'd like to know about his fluid status. Commonly, patient coming to the emergency room because of gastroenteritis, vomiting, and diarrhea, and you need to assess their fluid status. Are they hypovolemic? Are they hypervolemic? Or are they euvolemic? On the other hand, also, electrolytes imbalance is a common manifestation and representation in children presenting to the emergency room with various reasons. Talking about fluids management, as you know, 80% of children body water is a fluid, and 2/3 of it is in the account in the intravascular volume, and 1/3 is in the extravascular volume of space. If we talk generally, patient or child gain 1 liter gain 1 liter of water, he gain around 1 kilo. So basically, the same amount of fluid that he gain is going to be translated into weight. The other part of the fluid could be stay in the body is the third spacing, or what we call it fluid shifts, when the fluids is accumulated in an abnormal position. And this is could be in the peritoneal cavity, in the pericardial sac, intrapleural space, or at the joints. Causes of third spacing, either massive inflammation, venous obstruction, low serum albumin, a patient with, like, for example, nephrotic syndrome, or patient with renal or hepatic disease, when they lose significant amount of the albumin, whereas the oncotic pressure will be low and the fluid will be leaking from the intravascular to the extravascular space. For a reason or another, patients who have increasing blood volume, either iatrogenics, patient received too much fluids in the emergency room by inexperienced staff, or patient received iatrogenic blood product that was not calculated well, which lead to third space. I'm just going to go with this case scenario that it will tell you about, fluid management. This is a 6-month-old presented with history of diarrhea and refusal to feed for 2 days. So what do you think going on with this child?
This child would have dehydration because of the diarrhea.
Okay. So what do you think about his intravascular volume?
It will be decreased because all the fluid will be shifted to his GI.
So his intravascular volume is going to be low, and so his cardiac output is going to be low because his preload to the heart is going to be affected. So this is what we call it hypovolemia. Causes of hypovolemia decrease extracellular volume when they have either decrease in intake or increases losses. And increases losses like either vomiting and diarrhea, hemorrhage, or urine output. Can anyone give an example of somebody who have increasing urine output which lead to hypovolemia?
Diabetes insipidus.
Diabetes insipidus, or patient with severe diabetic ketoacidosis, when they lose a lot of fluids, they will be dehydrated, and then they will into hypovolemic stage. Back to this case, if we look to his examination, he's lethargic, his temperature is 36, his heart rate is 190, his blood pressure is 60/30, his cap refill is 4 seconds. So what do you think is wrong with this child in regarding to his presentation and vital sign?
His capillary refill increased and he's lethargic. At his age, he should be active.
Okay. So he's lethargic.
And his heart.
Why we think he's lethargic?
Because he's dehydrated.
And why again? What's if
Because of the low cardiac output.
Okay, which organ we think has been affected if he's lethargic?
The brain.
Sorry?
He would have the lack.
Brain. He's not perfusing his brain. What do you think about his temperature?
Hypothermic.
Yes, which could be again a sign of shock. What do you think about his heart rate?
Increased.
Increased.
Yeah. So his tachycardic and the blood pressure?
Very low.
Increased.
So the question, and his capillary fill have prolonged capillary fill. So is he in shock?
Yes.
I think he's a pre-shock.
Pre or shock?
I think he's in shock because of the hypothermia and also because of the increase in heart rate.
Okay. So what is the degree of shock that this patient has? We call it a decompensated shock because he's hypotensive. He's tachycardic hypotensive, so a decompensated hypovolemic shock. So how to manage? He needs to be resuscitated with fluid boluses, normal saline fluid boluses. You need to check an input and output chart and replace his losses. If you keep vomiting or keep diarrhea, you need to replace his loss and treat the cause. And this patient is probably viral gastroenteritis. We don't have a definitive treatment. We just only support him with fluid management. Moving to the other hand, patient with hypervolemic, either because of fluid retention or iatrogenic giving too much volume, or because of endocrine causes like hyperaldosteronism. What is the manifestations of patient with hypervolemia? Is usually patient will be hypertensive, patient will be fluid overload, sign of fluid overload like puffiness around the face, major chest wall edema, pleural effusion, or ascites, or swollen lower extremities. Let's move to this example. This is a 6-month-old boy diagnosed to have bacterial meningitis, noticed to have puffiness around the eyes, and his serum sodium is 126. What do you think his diagnosis in regard to his fluid?
Hyponatremic.
Secondary to
the meningeal infection that he had.
Are there any correlation between bacterial meningitis and hyponatremia?
Yes, it can cause the syndrome of inappropriate eating.
Very good. So this is a complication of meningitis might lead to syndrome of inappropriate ADH. What do you think about his intravascular, his total body volume? Is it normal or low or high?
I think it's high. You can have high intravascular volume.
What do you think about his urine output?
It's going to be low and concentrated.
Okay, so this is his intravascular volume probably is normal. His total body volume is going to be high, and here his urine output is low because they are retaining some fluid. And this is a known complication of meningitis. And they just treatment, how you are going to treat this condition?
Diuretics?
Usually we restrict their fluid. Majority of them, after restriction their fluids, their urine output improve, the total body volume will be less, and only in difficult cases that they are not responding to restricting their fluid, you may need to use a diuretic. We are going to move now to major electrolytes. We are going to have more during a small group discussion about more type of shock and how to manage each type of shock. Meanwhile, we are going to move to major electrolyte. And you just need to know that is most of his electrolyte imbalance is non-specific. They will lead to non-specific symptoms, and it's very difficult sometimes to figure out if this patient is hyponatremic or hypokalemic or hyperkalemic, hypocalcemic, hypomagnesic, and you always need to measure their electrolyte to know which type of deficiency that this patient is having. And majority of them, when they presented with non-specific symptoms. So that's why if you are not sure what we are dealing with, sometimes patient presented to the emergency room, we always ask for electrolyte because we cannot diagnose in the clinic. Major cation is a sodium, potassium, calcium, and magnesium, and major anions is the bicarb, chloride, and phosphate. And sodium is account the majority of the extracellular, and the potassium is majority of the intracellular. Going to go in each one, and we've just tried to highlight the importance of each electrolyte and trying to see are there any way we could predict these electrolytes imbalance. We start with the sodium, with the hyponatremia when you have sodium less than 135. And always you need to make sure when you are encounter for electrolytes imbalance, you need to know, is it an acute or a chronic? If it is an acute, probably your quick management is indicated and needed. If it is a chronic, make sure that you don't over-treat and you treat them gradually, because they have a number of complications related to acute management of the chronic electrolytes imbalance. Patients have been used to hyponatremia of like 130, 131. Is different from somebody who's acutely dropping his serum sodium from 140 to 125. So always looking to the previous measurement is important to guide you how quick is your intervention and management is done. Just remember, as the sodium is supporting neurotransmissions, hyponatremia could be decreased in intakes or free water gain. Somebody drinking a lot of water, they might be hyponatremic, or renal losses in case of patients is losing a lot of sodium in his urine, like cerebral salt wasting. And what is the manifestation? It could be anorexia, nausea, vomiting, is all non-specific symptoms. If it is severe enough, it might cause irritability, seizure, decreased level of consciousness. So when we are dealing with somebody who have decreased level of consciousness, could be one is his differential diagnosis, electrolyte imbalance. He could have other reasons like trauma or bleed or other, but we should always make sure we measure electrolyte. How to treat the sodium loss and treat the water access. If somebody is losing a lot of sodium, somebody is vomiting, probably you need to resuscitate him for fluids management and trying to stop his vomiting, or treat the water access. On the other hand, hypernatremia is sodium more than 145, either because of water loss, like patients with diabetes insipidus, they lose a lot of free water with their urine, they will be hyponatremic, or somebody, patient getting a lot of sodium, or patients have been treated in the past for hyponatremia and now end up with hypernatremia because his management was not monitored. Causes of hypernatremia or manifestation of hypernatremia could be just sign of dehydration, decreased level of consciousness, or intracranial gain. How to treat hypernatremia? Hydrate and treat the cause. If somebody have diabetes insipidus, you need to get him hormonal replacement to decrease his free water losses. On the other hand, potassium. Potassium is an important intracellular ion, is important for normal neuromuscular and cardiac function, maintained by cellular sodium potassium pump and eliminated by the kidney. Always, if you have hyperkalemia, you need to know is the kidney is functioning well or not. Make sure patients with cardiac disease, you monitor their potassium, especially if they are taking other cardiac medication like drugs. Causes of hyperkalemia, either increase intake, excessive rapid delivery of potassium, blood transfusion. All blood transfusion might have low potassium. shifted of potassium from intracellular to the extracellular, like in acidosis, or patients with increased cell lysis, like tumor lysis syndrome, when there is a breakdown of malignant cell which release a lot of potassium, or because of renal function. Before any correction of the potassium, you'd like to know about the kidney function. Again, if you go to a manifestation of hyperkalemia, again, it could be non-specific, weak muscle, weak skeletal muscle, irritability, arrhythmias, and then ECG changes in regard to peak T wave, short QT interval. To progress will lead to wide QRS and depressed ST segment. And this is what the first manifestation of hyperkalemia, when you will see a tall, big T wave, and then it will progress to wider QRS and QT arrhythmias. Again, this is when you see an ST segment depression. On the other hand, hypokalemia is because of decreased intake of potassium. Sometimes you keep patient MBO, you give him plain IV fluid without a maintenance potassium chloride, or increased cellular uptake of potassium. Diabetes ketoacidosis is a common cause of hypokalemia. Somebody who's vomiting, they lose a lot of potassium. Diuretic also could cause increasing the losses of potassium, or hormonal because of increased aldosterone. Manifestation could be non-specific. There have been some changes in regard to some BPCs, could lead to confusion too. Make sure when you correct hypokalemia, you need to be slowly, not more than 10 mg per hour. Potassium can cause pain and necrosis of the vein, and you need to consider holding diuretic in specific. This is when you have little weight and you wait in patients with hypokalemia and ST depression. Calcium is an important cardiac muscle contraction. Any patient who have cardiac disease, any patient who is hypotensive, you may need to make sure you measure ionized calcium and to make sure it's within normal. Calcium is also important to see in this disease. Patients have been presented with seizure, you make sure that you measure his calcium, his sodium, and his magnesium. Is helping in blood clotting factor, formation of teeth and bone, and also helping in muscle contraction. It requires vitamin D, parathyroid, and calcitonin. Hypocalcemia with the serum calcium less than 2.1, or the ionized calcium less than 1.2, could be related to nutritional deficiency, which is very common in children, especially nowadays, patients, or especially cold weather, not exposed to sun and others, or during the past curfew when there is no exposure to the sun. Parathyroid deficiency, blood transfusion, and bone cancer when you're eating the bone and eating the calcium too. Very important sign, you need to always go for chopstick sign and trouser sign. This is the sign of hypocalcemia. This is maybe you need to Google it and you're looking for actual sign, and probably this is because of irritation, ischemias. When you do trouser sign, you are inflating the capillary, so you're reducing perfusion to the tissue, which will cause irritation to the nerve and cause tetany. Abdominal cramp and diarrhea, arrhythmia. Seizure is common in patients with hypocalcemia, paresthesia, and ionized calcium is very important to measure it in this time of children. Phosphate is very important, especially in patients with renal disease. Always, if you have hyperphosphatemia, you need to make sure that the phosphate level is not high, because the phosphate is excreted by the kidney and stored in the bone. So any patient coming with hyperphosphatemia, check his kidney. Magnesium is a good bronchodilator. Is also patients who have a seizure. Always you need to rule out hypermagnesiemias. Just remember, magnesium affects other electrolytes like calcium. Magnesium has been recently shown as a good bronchodilator. So in patients with asthma presented to the emergency room, you need to give them magnesium as a bronchodilator, will help their asthma management. Hypermagnesemia, you could have a muscle weakness, bradycardia, hypotension, nausea, Hypomagnesemia will cause neuromuscular irritability, muscle spasm, tetany, and seizure. So if you have seizure, you need to rule out electrolyte imbalance, hyponatremia, hypocalcemia, and hypomagnesemia. This is what I do have for today. If you have any question or you could ask, just remember that hypercalcemia, electrolyte imbalance is common in children, very difficult to diagnose if you didn't look for it, if you didn't measure it. It could carry morbidity and mortality if you not recognize it early and if you didn't manage it early. I'll just leave if you have any questions, feel free to ask.
Thank you, doctor.
Any question?
No, doctor. Thank you so much.
Thank you.
Thank you.
Thank you.
Okay, doctor, thank you.